Lovely, thank you. Welcome everybody to our Early Intervention and Behaviour Change theme meeting for the North East North Cumbria ARC. We've got a real good number of people with us today, and also some excellent speakers and a really packed programme. So I'm not going to spend any more time welcoming you all. We have got an opportunity just on the agenda there, thank you, Rice, to see that we're going to have an opportunity at about 12:15 just to have a cup of coffee, if you can make one in between whilst listening to the guest speakers, or someone can bring you one, and a chat. And I think we're going to, because of the numbers of people with us, we're going to go out into some breakout rooms for that, and that is something that you all asked for previously, in that an opportunity for a bit of informal networking. So we'll see how that goes, and again we'll be asking for some feedback on that. So just to say to you that we are recording, and be aware of that we're just recording again, just for our notes and reflections on the meeting. So I think I'm just going to check I've got no other housekeeping to give, and we'll move on. So yeah, these are, I think you've already been given these, in that if your videos, if there's any problem with bandwidth, just turn your video off. But when we're in discussion and questions, please could you turn that on, and do use the chat box. That's enabled for people with their questions. Okay, so I think now I'm passing over to Mackenzie and to Rice to tell us a bit of an update on some of the theme activity over the last little while. Okay.
Thank you, Ashley. So just very briefly today, I'll focus on a couple of projects that we've come to the end of. So we've got some findings to share with you. Firstly, the rapid review of parental health behaviours and infant care practices during pandemics. So just a quick refresher to the context of this study, which some of you will have heard of already a couple of times. So as we all know, COVID has affected all of us across generations in different ways, and the impact on the pandemic on infants and their caregivers are less well known. And they're really important to identify, particularly given the first 1001 days of a child's life being linked to their health and well-being outcomes later in life. So we wanted to understand how caregivers took care of themselves and their babies during pandemics. So we undertook a rapid review, the methods of which I won't delve into here in the interest of time, but I'll pop on the link to the Prospera registration page later on in the chat for you if you'd like to know more. We screened 5,451 records after removing duplicates, screened 60 records in full, and identified 20 studies that met our eligibility criteria for inclusion in our narrative synthesis. So these studies were conducted in various pandemic contexts, 12 of which were during COVID, 6 of which were during the 2009 H1N1, 1 during the 2016 Zika outbreak, and 1 during the 2003 SARS. So we identified a range of behaviours that were explored in these studies, and they're listed on this slide. And just a few key highlight findings. So in terms of adherence to guidance, including hygiene, practices remain variable across countries, but there's no evidence to suggest that adherence is higher in a pregnant population. In terms of accessing care, pregnant individuals deferred or cancelled antenatal appointments and changed their decisions on choices regarding birthplace. There's also some evidence to suggest that elective C-sections increased during pandemics. In terms of diet and physical activity, overall, there has been no reported change with respect to diet before and during pandemics, but sedentary behaviours increased. In terms of information sharing, social networks, the media, and the internet were key sources of information, particularly around vaccinations and perinatal care. Regarding vaccines, parental decision-making on getting vaccinated is consistent with the general population. So in particular, Black women were less likely to receive vaccines compared to other ethnic groups. And again, this is comparable with the general population literature. Lastly, on self-care and mental health, coping mechanisms included connecting with personal networks virtually, which is to be expected. And for some, there were some perceived benefits, including increased family or bonding time. So We've identified that parental behaviours do change in response to pandemics, but the extent to which these behaviours differ from the general population still needs to be established. Women were less likely to attend in person for their antenatal care during pandemics, and were also more likely to have an operative delivery. So the potential impact of these behavioural changes warrant further investigation. Vaccine hesitancy is common, and information sources on vaccines did vary, but the impact of information sources on vaccine acceptance needs to be assessed. Finally, expectant and new mothers experienced heightened anxiety during pandemics, and the self-care behaviours that they might have engaged with to counteract their anxieties might be restricted to these particular contexts. So there's a need to explore whether any of the perceived benefits that they've experienced, such as having more family time, is experienced by everybody, or if it is restricted to particular groups, for example, high income groups, or where families where both parents were present or cohabiting. So we hope that the findings from this review inform future planning for pandemics and guide COVID-19 recovery strategies as well to support new parents and their children. So next is the study where we looked at health visiting services in our region during COVID-19. So again, just a really quick background. Health visitors are specialist community public health nurses that are key care providers for families with children under 5 years of age. So we know that COVID and the related restrictions resulted in staff redeployment, increased workloads, and rapidly changing service delivery models. A national survey of health visitors in June last year found that approximately 60% of those surveyed reported at least one member of their staff member being redeployed. So these resulted in the profession's concerns around being able to address families' needs, such as identifying early warning signs for poor perinatal mental health, also experiencing reduced ability to provide support, particularly with breastfeeding support. So to add to this, there is limited research and research capacity concerning health visiting services and practice. So for this particular project, we aim to explore the adaptations to and innovations in health visiting services in our region in the context of COVID, as well as work with the third sector to build health visitor research capacity. But in the interest of time, I'll focus on the first aim. So to explore health visiting services, adaptations and innovations, we undertook a selected document analysis, a survey of the health visitor workforce in the North East and North Cumbria, and then also conducted interviews with key informants, including service managers and leads. So we reviewed the available reports on health visiting services as pictured below, and these focus on the national impact of the pandemic on health visiting and practice innovations. So two key findings from these reports are that there is a need for practical and social support for the health visiting workforce, as well as the need for evaluative research to inform the shaping of the workforce and future service delivery models. So we used the information from the document analysis to develop a survey of health visitors, and we invited approximately 660 of them and received 258 responses. The graph on the right shows you how the 6 mandated health visiting contacts, so from pregnancy up until the 2.5-year check, have been delivered during the pandemic. So either face-to-face, which are the orange bars, the telephone contact, which is yellow, and then virtual contact, which is green bars. And we found that most of the mandated health visiting contacts were carried out face-to-face throughout the pandemic, but you'll notice that these are focused mostly on the new birth visit and the 6 to 8 week review, which are the 2 middle bars. So with contacts on either side of these being delivered remotely. So health visitors also reported a range of service adaptations, and the most kind of commonly reported ones were the face-to-face appointment-only clinics, having a duty line, and also implementing virtual infant feeding clinics for additional support. And then we also asked the health visitors about their perceptions of the quality, access, and continuity of their services before and during the pandemic. So in terms of the quality of service delivery, this seemed somewhat worse or about the same when compared to before the pandemic. And then in terms of access to services, this was found to be somewhat worse by health visitors. And then finally, in terms of continuity of services or support, they found this to be about the same. In terms of accessing support for families, health visitors reported that during the pandemic, children's centres, GPs and therapies were the most difficult to access. So to explore our survey findings about these adaptations in greater depth, we interviewed key informants analysing the data using the normalisation process theory, which is a framework that allowed us to explore the factors that either supported or hindered the incorporation of interventions into everyday practice. So we interviewed 20 individuals and included 19 in the analysis, so we had some missing data there. Here are the key themes that we've identified, but again, just in the interest of time, just a couple of highlights. So the health visitors and health visitor leads that we interviewed reported introducing virtual contacts, and when and how this was implemented varied, with some virtual contacts being aimed at facilitating interprofessional communication, whereas some were aimed at linking with families. All the interviewees highlighted that the face-to-face aspect of health visiting is critical to the identification of needs and provision of long-term support as well. So during the pandemic, where many services were stopped, particularly the limited access to children's centres, which we also found in our survey, the importance of interprofessional working became more apparent, particularly for information sharing. Health visitors found their services innovative in nature, but found a lack of coordinated response from employers and service commissioners hindered them from planning and delivering their services appropriately. That said, health visiting teams drove adaptations to ensure that families' needs were met, and they reflected on the role of the innovations in their practice going forward. They identified a lack of formal evaluation so far of these innovations, and we're keen that these were investigated further to understand the impact on their profession and service commissioning. So very quickly, this slide just summarizes some of the key recommendations. So in particular, the need to maintain face-to-face support for families and supporting interprofessional working, including providing virtual communication tools, and finally supporting health visitors in developing and evaluating service innovations that they've implemented to inform COVID recovery planning. So that's it for me today. I'm going to pass over to Mackenzie now.
Thanks, Rice. So I'm going to start off by talking about a project that Rice and I recently completed, obesity prevention in the northeast of North Cumbria and connecting with the third sector. Next slide, please, Rice. So third sector organisations, which include voluntary, community and social enterprise sectors, are recognised as being a growing provider of public, social and health services. In terms of their role in primary and secondary obesity prevention, they add support beyond NHS and commercial provision, which tend to be more management and treatment focused anyway, compared to obesity prevention. They have greater local knowledge, so they have better knowledge of local people, environment, resources, and most operate at a neighbourhood and village level. And they're potentially better at connecting with harder to reach groups. So for example, let's say you have middle-aged men who perhaps don't engage with primary care as much as they should. They may be more interested in participating in third sector football organisations, for example. So they have clear value and relevance, but it's hard to know what's out there. They're also varied. It's hard to know what they offer and who they offer it to. The next slide, please, Rice. So we set out to identify and characterise third sector organisations in the region that contribute to obesity prevention. So specifically, we wanted to identify those that target energy balance behaviours, so dietary intake and physical activity. We wanted to collect data on what type of organisation they were, their funding, geographical catchment, activities and services, if they had been previously evaluated for effectiveness, do they collect any routine data, etc. So a lot of things we were collecting. In terms of methods, we conducted a digital search, so Google searches, going onto funders' websites like the National Lottery Community Fund. Social media was a really good source as well. And where we found that there wasn't sufficient information that could be retrieved online, there was some direct communication with key stakeholders as well. Next slide, please, Rice. Thank you. So we ended up producing an inventory of all the third sector organisations in the region. In the interest of time, I'm just kind of going to go through some key high-level findings. But basically, there's a huge diverse range of activities and services that are offered by these third sector organisations. Next slide, please, Rice. So we identified a total of 59 third sector organisations across the region. So Cumbria County Council had the most with 8, but there are 11 that aren't associated with a particular location that have region-wide reach. And most of them, so 28 of those 59 are registered charities. Next slide, please. So when we look at obesity prevention provided within each location, we can see here in orange that most activity and services focus on physical activity only. So 34 of those 59 were physical activity based. And diet was the least reported activity. Next slide, please, Rice. So now looking at target group, we can see that most activities and services were offered to adults only, so 29 of the 59. They're in orange. Next slide, please, Rice. And here we have cost to participants. So most were free, although should be noted that a few of them didn't actually have price information available. Next slide, please. And this sunburst brings everything in together. So it shows results first by area on the inside, so location, then by area of obesity prevention, so diet or physical activity, and then finally by target group, so adults, children, etc. on the outside. And I realise that text is way too small, but that's just to kind of show the complexity of it all. Next slide, please, Rice. So now we have an understanding of the geography and the characteristics of these third sector organisations, but it raises a few more questions around their uptake and their reach. So who engages with these services and activities? Is there any kind of evidence of effectiveness? You know, if there is a good evidence base, that has implications for policymakers who may consider investing more in these organisations. You know, it would be interesting to look at good practice and innovations. What is their place among private and public provision? And also a question around sustainability of this inventory itself. It's quite a useful inventory to have, and it might be useful for healthcare providers to refer people to these organisations. So how can we keep this inventory up to date? Next slide, please, Rice. Thank you. So next I'd like to talk about another project, so planning regulations, hot food takeaways and COVID-19, so looking at consumer insights in the Northeast. Next slide, please, Rice. So before the COVID-19 pandemic, planning regulations mandated that only A5 takeaway or fast food outlets have been able to offer enhanced takeaway services and delivery services. But since the COVID-19 pandemic, obviously restaurants, pubs, bars were closed. So there were changes to the planning regulations, which meant that these types of outlets were able to also offer takeaway and delivery services in an attempt to kind of help them out economically. So these changes were meant to last until March 2021, but they've been extended to March 2022, and there's talk about these changes becoming permanent. Next slide, please, Rice. So for this piece of work, we wanted to explore the experiences and perceptions of adults living in the north of England around accessing and consuming hot foods prepared outside of the home. And we wanted to look at experiences before and during the pandemic, including as restrictions have been lifted recently. And we also wanted to explore the effect of moderating variables on consumption of hot food. So looking at things like BMI, density of food outlets and food insecurity. Next slide, please, Rice. So very briefly, in terms of methods, we wanted to align our data collection with the easing of restrictions. So after April 12th, when outdoor hospitality was opened, we launched Survey 1 to around 700 participants living in the north of England. We asked questions around demographics, usual food intake, and how people were eating from different outlets over the previous 7 days. Restrictions lifted further on the 17th of May, which meant indoor hospitality reopened. We launched Survey 2 to the same sample of participants as Survey 1 following this, and we also conducted some focus groups in 22 participants. Next slide, please, Rice. This is just to show you a screenshot of the survey that we launched, just to make that distinction between the two different types of outlets. So the A5 outlets we named as fast food outlets, and we described them as places that mostly serve takeaway and delivery due to limited seating, that foods were normally purchased at the till, for example. And for the bottom group, which we labelled as restaurants, pubs, bars and cafes, we said that these were mostly dine-in, there was plenty of seating and it was mostly table service, and food required a bit more preparation. Next slide, please, Rice. So some very quick high-level findings. So we ended up collecting data from 704 adults. We got a nice diverse sample in terms of age, sex and income. Most people lived in the northeast. Most participants were white. Most reported that they're able to have food delivered to their home by delivery services like Deliveroo. And almost 30% reported experiencing food insecurity to some extent over the previous 12 months. Next slide, please, Rice. So these data show the frequency of eating out before the pandemic, so before March 2020. So fast food outlets are shown in purple and outlets in the restaurant pub group are in yellow. So for both groups, the most common response was eating out 1 to 2 times a month. Next slide, please, Rice. So we can see here in the purple, so when participants were asked how often they ate out in the previous 7 days, 60% reported eating from fast food outlets at least once, compared to 20% in the restaurant group. So looking at the frequency, we can kind of see that there's potentially a trend for people to be eating at fast food restaurants more commonly or more frequently now than before the pandemic. Rice, in the interest of time, would you be able to skip ahead to one more? Thank you. Sorry, go back up one. Sorry, just very briefly, because I know I'm running out of time, I just wanted to share some findings about the focus groups. So we haven't coded these, but themes that have been emerging are that eating out is linked to socialising, celebration, family, culinary experience. During lockdown, people made mention of kind of date nights at home, trying to experiment a bit more with cooking. They had kind of fine dining meal kits delivered, and there was more awareness of local and family-owned businesses. Some positive experiences that people made mention of eating out kind of recently as restrictions were lifted were outdoor seating, better spacing of tables and great awareness of hygiene. Negative experiences were having to book, there was no spontaneity in a night out anymore, not feeling particularly safe, but reporting that they would feel safer after vaccination rollout, and a reduced sense of ambience and atmosphere at dining outlets. I think I'm going to pass over to Ashley, please, as I'm very aware of time.
Thank you so much, Mackenzie and Rice. And that was a whistle-stop tour through 4 projects. And I think I'd just like to congratulate Mackenzie and Rice on being able to obtain funding from both PHE, but also from other sources, including small funding from Wellcome and the university, to complete those pieces of work, and in the constraints of the pandemic, and they're all very relevant. We've gone from maternity care to takeaways in 15 minutes, I think, and a real range. So those slides will be available on our website, and there's also a brief on those projects. And perhaps in our discussion sessions a little bit later on, it would be really interesting to reflect on some of those things, particularly for example, the inventory on third sector obesity services and how that might be made accessible and be most useful to other people in this group, in terms of that huge piece of work that's been done. Okay, so we'll hopefully have a little bit of time for questions and also discussion a little later on, but I'm going to just move us on, and I know a number of you will be very curious to find out what's happening with the open funding call. So this has not quite closed, but we're getting very close. If you just like to go on to the next slide, right, so this is the timelines for this was that the expressions of interests were invited, and we received across the arc 177 expressions of interest. 30 of those were submitted under Prevention, Early Intervention and Behaviour Change, and thank you to all of those who let us know that you were submitting those. And we've been in touch, Anne has been in touch with all of those, all of you, to check whether you are actually going to submit. And the submission date is Wednesday, 12 p.m. I'm thinking that is at 12 p.m. midnight or 12 p.m. noon. I'm not sure, but I'm going to ask if anybody else can confirm that for me. But it's Wednesday, so it's not far off. Applicants will. Sorry,
it'll be noon.
It'll be noon. Okay, so that sounds sensible, Eileen. So lunchtime on Wednesday. So I hope everybody who's involved in those, your applications are all going well, and you should have been given a form of words to include in that in terms of involvement within the theme. Applicants will be informed of the outcome in November, and the projects are due to start between December and 31st of March. What I don't know right now is how many of those 30 will be progressing to full submission, but we'll know that by Wednesday. Okay, so I'm just going to tell you a little bit about national priorities and so forth in just a moment, but I can't see everybody's hand, but is there anybody that wanted to ask any very brief question about the open funding call? I don't think we've got any more to say on it than what I've just presented. I'll just check. Can anybody see if anybody's got any hands up? I don't see any, so I'm going to move on. Okay, great. Well, good luck with that, everybody. And now just a really brief update on terms of the national priorities, the Prevention with Behavioural Risk Factors Consortium. So we talked about this before at meetings. The North East North Cumbria ARC has the responsibility for the Prevention with Behavioural Risk Factors Consortium, but also the Health and Care Inequalities Consortium. And that one is led by Claire Bambra, and we lead the prevention of behaviour risk factors. So this has been progressing, and just on the next slide, these are the projects which will be funded through the additional funding we have been given, 1.8 million additional funding for projects across ARC to have collaboration across all of the different ARCs, and we have 15 ARCs involved in this collaboration, and at least 12 of them are involved in these projects. So you'll see that we actually just at the end of last week got confirmation from NIHR on our work plan, so these projects will go ahead. We are leading the evaluation of implementation of hospital-based tobacco services. We're also involved in the project looking at workplace initiatives, and that will include our Better Health at Work award here, and that's been led by ARC West Midlands. There is an evaluation of the NHS incentive for weight management in primary care, being led by Oxford, and North East North Cumbria ARC are involved in that. There is a third project on the scale up of weight management in type 2 diabetes, being led by ARC North West London. And the fifth one is about domestic violence advisors provision in maternity settings. And that's been led by South London, but we are co-funding that one with the Child and Maternity Priority Consortium. So 4 projects that we are funding within our consortia, and another that we're funding across 2. And these are all now progressing, and we are involved in 4 of these 5. Eileen, did I see your hand go up? No. Okay, great. So it's really just for information, and these projects will now begin in September, and we're developing a comm strategy that will be able to promote these, and that will be held on our North East North Cumbria ARC website. So really exciting to be at this stage to get these projects going. Okay, so that's me, and so just if we could just move on to the next slide, please. And I'm delighted to be able to invite Matthew Scott, who'll tell you a little bit about his insights report. And I attended the ICS Prevention Board. Matthew presented this work, and I thought that this was something that would be of interest to this group. So I'm really grateful to Matthew for being able to attend today and to share the findings of this report. So Matthew, I'm hoping you're with us.
I am.
That's fantastic. Over to you, Matthew. Thank you.
Okay, well, thanks very much. So I think my slide's going to be operated by someone else. Oh, that's good. It's all working. Look, the technology works. That's good. So yes, I'm just going to kind of rattle through some slides here, and then if there's time, I'm happy to take some questions, or maybe in the section afterwards. So you have to cast your mind back pre-COVID quite a long time to engage with this piece of work, but I think it's quite interesting, especially reflecting on some of the findings from the 4 studies that Mackenzie presented on just now. So basically this was during autumn 2019, we were asked by the ICS across the Northeast and North Cumbria to conduct a sort of initial conversation about wellbeing with the public and with staff across the region. We managed to get a really high engagement rate with 3,250 people, which was made up of nearly 1,000 staff from the health and care system across the region, and over 2,000 members of the public. And we also added to that by conducting, I think it was something like between 15 and 20 focus groups with seldom heard groups across the region that were run for us by the local health watch organisations. And then we compiled all this information. If we go to the next slide, we asked a series of questions. I'm just going to pull, I mean, there's lots and lots of data. There's a number of reports that we produced from this, but I'm going to take this at a very, very high level in order to fit it to time and just sort of really reflect on the main points that I think we took away from the piece of work. So really, we asked a series of questions about what well-being meant and people's understanding and interpretation of the concept of well-being. And we also married that up with asking people about what matters most to them. And there was quite a lot of commonality and overlap between lots of different groups in terms of members of the public, but it also very much overlapped and conformed with the views that staff held, which is reassuring. So people are thinking about this in the same way. And the kind of 3 main areas were about being socially included. So about feeling loved, being with family and friends, being close to them, and also about feeling part of a community. And the concept of community was quite a broad definition. So there are communities of interest, communities of location, communities based on ethnic or religious grounds as well. But those were the really important parts, and that all kind of came under a sort of feeling socially included and not isolated and not lonely element to what well-being meant to them and what mattered most. There was also an element about feeling well looked after, and that was when I think people were applying it more to health and care services, but also in terms of their relationships, that where they felt listened to, where they felt cared for. And that comes up as a bit of a recurrent theme later on. And then the final element was a very strong message about people linking well-being to being physically and mentally healthy, about how to manage stress well, about very much about linking it to being happy and feeling content in yourself and with your life and lifestyle, about being fit and active. Being active and being physically capable was really scored really highly in terms of what well-being meant to people and what mattered most to them. And that really boiled down to actually people being able to do the things they wanted to do in their lives. So we can move to the next slide. So we asked a lot of questions across these different interactions, which were part online survey, focus groups. We did pop-up kind of stands in workplaces and shopping centres. And some of the conversations we had highlighted a lot of strengths about the health and care system and the ability to engage with conversations about well-being. I think the main one was really about the public being very open and willing to have a conversation about well-being. They had a clear concept of what it meant, what the term meant, what the language meant to them. Also, most people rated their well-being as okay and felt optimistic about how this would be in future, which felt like a kind of positive strength to build on, that people understood the concept of having a dialogue around this and felt that this was something they did want to build on and would be able to. Around 3/4 wanted a collaborative decision-making partnership with health and care staff if they became ill. So they saw you know, they understood and took some of their responsibility for their own health and well-being and wanted to work in partnership with services. And around 60% said that they felt that they personally were the most responsible for their own well-being and felt that they were experts in their own care, and also felt confident that they were able to make changes. Now, I know that a lot of data around how complex and difficult it is to effect behaviour change and to maintain it, especially around some of the health and well-being issues in public health, would perhaps challenge that, but at least there was some optimism and belief, self-belief and willingness to engage across that group. And then in staff, we saw that reflected in most staff said that they felt at least partially able to support people with what matters most to them. And most felt that the public felt at least partially supported by the health and care system, and that the things that they felt were important were about listening to people and caring for them. And most people felt in the public felt that they wanted staff to be role models, and that was something that had come up in earlier discussions about whether staff didn't necessarily feel secure in being a role model, or felt that that was the role they should have in terms of modelling positive health and well-being kind of conversations or behaviours. But actually this was something that the public wanted. And most of the public preferred to talk to, interestingly, most of the public preferred to talk to their family about well-being in the first instance rather than to services. Staff also felt ready to use more digital support in order to help people with well-being, but they felt that the infrastructure was not yet there to allow for this. If we can move on to the next slide. So that was something, again, that was quite interesting, that the staff felt ready to engage more with digital tools, but didn't feel that they were necessarily, the infrastructure was there to allow them to deliver that yet. Unsurprisingly, a number of gaps are kind of flagged up through this process. A number of people raised the issue around unsustainable health and care services. So there was a kind of popular belief, and this is pre-pandemic, interestingly, that so although people felt generally positive about the health services they received, there was general agreement that there was an over-reliance on GPs, and that they felt the service levels for hospitals and GPs were unsustainable. And that people were actually, there was a fairly broad acceptance that the health service couldn't just keep expanding exponentially given the constraints on funding and limits to staff and all of those sorts of things that people know about in the system. Then people were also talking about the need to boost self-care within what health and care services deliver. So I think there was a kind of understanding between the staff and the public that actually a lot of health and care service delivery is about responding to crisis situations and when things go wrong. And they felt that actually perhaps more responsibility needs to be put on to members of the public for looking after themselves better, and that actually that more of that emphasis on preventative work should take place, and that there was a real role for health and care staff to enable and push the public to take better care of themselves as a preventative measure rather than always just responding when things go wrong. And then we looked a bit at the whether the response to you know, the need to boost prevention was strong enough, and we felt there was a bit of an underpowered response. So around half of all the staff members we spoke to said they don't feel they get to tackle root causes of ill health in their job. Around a third said that they weren't actively promoting well-being within their work, and around a quarter said they didn't feel empowered in their role to give self-care messages. Some of the programs that we were told about in terms of making every contact count, social prescribing and All Our Health, which were there to help health and social care staff to deliver some of these messages, we found that less than or fewer than half of the staff had actually heard of those programs, let alone were delivering them. And we also interestingly found that those gaps in terms of knowledge of programs and empowerment to deliver self-care messages were the lowest in frontline staff and team leaders. So actually some of the knowledge was higher amongst administrative and commissioning staff, but less on the ground. We also found that around 1 in 4 practitioners and team leaders say that they felt they couldn't support people with what matters most to them, as it was not part of their role. So if we can have a look at the next slide, please. I'll try and hurry through these a little bit, conscious of time. So we found as well, in terms of the kind of ability of services to respond to a desire from the public to be given guidance around wellbeing, that staff were worried about giving self-care messages, and they were concerned that this could alienate patients, where patients felt that it perhaps wasn't the staff role, but as we've heard earlier, the majority of the public felt that health and care staff should be delivering well-being messages and should be acting as a role model. So as we said just now, that many staff didn't feel empowered, confident or skilled to give that kind of self-care advice, or said that it wasn't considered to be an important part or priority element within their role. Staff also reflected on this, saying that they didn't feel that prevention and self-care messages were clear enough or joined up enough. So I think this was sort of relayed to us in terms of they felt there were, you know, sometimes just delivering smoking messages, sometimes just obesity messages, and everything was very segmented. And they felt that actually it would be better brought together under kind of lifestyle management choices that, as many of the people they were concerned about would have needs in a number of those different categories, but they felt they had to kind of use different tools or have different messages and different campaigns. That meant actually this was quite broken up and segmented, and made that hard for them to join all those messages together. A number of staff also highlighted the fact they felt that people were routed too quickly to the GP and A&E by default, and that created huge levels of service demand, where sometimes actually putting more of a prevention message, encouraging people to use pharmacies or community services more, or asking people to be more self-reliant and using the NHS phone services as well was perhaps a better route to go down if you wanted to reduce some of the service demand. Also, we highlighted within the public responses a small but significant group, around 12% of the public, who were being a bit left behind, where they didn't feel supported by health and care services with what mattered to them. And they particularly cited long waiting times and not being listened to. So we looked into that group a bit more, and we found that they had much lower self-rated well-being scores. And this was particularly amongst those with long-term conditions or those who were unemployed. This also then was reflected in that they had lower levels of belief in certain self-care enablers, such as problem solving, having someone to talk to, or their ability or their belief in their ability to make changes. So we found quite a sort of hardcore group of people who felt that their health and care services didn't respond to them. They were often had a long-term health condition or were unemployed and outside that system, and felt that really they weren't supported by services, but they didn't have a lot of self-reliance and self-ability to make positive changes in their lives. When we asked that group about their experiences with health and care services, these two terms came up very often, that they often felt deflated or rushed by services, and that the net result of that was that they then felt unmotivated to take self-care action. So that sort of unsatisfactory interaction that they said they were having with health and care provision left them feeling they weren't in a position to actually act to take care of their own health. If we can move to the next slide. So in terms of recommendations that were generated through the discussions and through the analysis of data, there are a few kind of key themes. One was around further enabling self-care. So we felt that the key steps to take were around empowering staff to promote self-care in a much bigger way, make sure that it feels like it's everyone's responsibility, and actually put this in as a key part of certain staff roles. Also to build self-care capacity amongst the public by empowering them to build on what they see as their existing skills. So there are a lot of people who felt they had the skills to make changes, believed in themselves, felt they could use online tools reasonably well. But actually, you know, that group we were just talking about who didn't feel they could make changes, it's that sort of 10 to 12% of people who feel they're being left behind by the current system, that where the priority needs to happen for this self-care kind of capacity building to take place. And that might be much more of an intensive intervention needed than you would do for the wider population, where they had higher belief in their abilities to make changes and to use those tools. And we felt to really make this happen, that staff needed training, greater training and role security, and this needed to be pushed much more up the priority list around delivering self-care advice and wellbeing advice. And then the particular barriers that we found that made it harder for the public to engage in self-care are the ones that need to be addressed within this. So it was particularly in the long-term condition group, people identifying as having enduring mental health problems, people with high levels of stress or self-rated poor lifestyle, such as drinking and smoking and obesity. And then another major issue which came up across all the groups was about people feeling they didn't have enough time to conduct self-care, and that ranged from I don't have enough time to buy raw food and cook healthy meals, to I don't have enough time to go to a gym or join a sports club, or I don't have enough time to do something positive for my well-being, or I don't have enough time to relax and spend time with my family. So it was about So trying to think about how can you build some of the actions we want people to take into lifestyles that they feel don't allow any time or priority to those actions. And we also found about a desire to build more conversations about well-being just in general. So to prioritise addressing root causes rather than a sort of patch up and send out again that lots of staff referred to, that actually people felt that if it was pushed in their roles more, that they should be addressing root causes as well as that would have an impact on their ability to do that within their role. Also, we felt that there were some assets within the public that could be capitalised on, such and particularly 1 in 3 members of the public felt happy to give well-being and health advice to their friends and family. So there were potential advice givers, and that was particularly stronger amongst older people, amongst women, and amongst BAME groups. So we felt there was something there, and we've seen in other areas kind of public health champions being used as a potential source of basically outsourcing to the community some of those conversations to happen. And then we wanted to see a better engagement with programs such as MEC and All Our Health and social prescribing to make sure that it was actually part of the culture. We felt at that stage, obviously going back a bit, that fewer than half of the staff were aware of those programs, that it was clearly being a bit underused. And if we could just move to the last slide now, just to wrap up. So the final area was around maximising the impact of prevention communications as a key part of this. And people were advocating a push prevention approach, joining up a range of messages under a single lifestyle banner, which I think we touched upon earlier. There was also a feeling that there was a need for much more personalised messages rather than a one-size-fits-all approach. And we particularly, so in the data, you'll see we used a whole series of images, and we asked people to kind of vote on which ones looked like well-being and which ones they felt they would relate to. And the strongest images were always the ones that showed images of family and people that the sort of words that could be used in interviews and the ways to describe well-being. We've got a lot of information in our report about the sorts of images, words, and ways of speaking about well-being that would engage particular groups. So we've got all of that data broken down to maybe enable some of the thinking in the way that communications are used and personalized. Then there's an element about being better at explaining self-care actions that people can take. So rather than where people felt rushed and not prioritized or not cared for, they were less willing to take on the actions around self-care. But actually, we've got to think about how do we mobilize the apps and websites and members of the community and external resources that are there promoting well-being. How can we make that more a part of the kind of advice that health and care services give habitually to people, rather than a situation where we're kind of rushing through the healthcare, the medical response, but not necessarily thinking about how do we support people to not be back here again in the near future. And then also, how do we capitalize on that active partnership that people said that they wanted with health and care services? Are we being too top down and just kind of saying, right, here's the message, off you go, rather than trying to engage them in building that response themselves and capitalizing on their own personal capital to help deliver that? There's also an element about guiding and helping the public choose the best apps to solve health problems. Interestingly, when we asked people about what they use to solve problems, most people said they did use apps and websites, but when we made that specific to health problems, they were more likely to ask a family member and then go to a pharmacist or a GP down the line that way. And actually they weren't using apps or websites as the way to solve health problems. And I think a number of members of the public told us that was quite hard to navigate, and staff said they weren't always clear on what the best apps were to advise the public to use. So they felt like that could be tightened up and made more prominent to get better value from that. Also, there was a discussion around promoting alternative routes to earlier or more preventative health and care services, particularly around use of pharmacists or minor injuries units or NHS telephone services or community services to deal with some of the lower down health problems, and that would, in turn, reduce demand on A&E and GPs. And also there was felt there was a need to clearly articulate at that point, and obviously I remember we're going back quite a while, to clearly articulate what the ICS is for staff and people, we found fairly low levels at that time amongst the public and staff about what the ICS was and what its role in relation to health and well-being was, who leads it, are they visible, is it their personal responsibility to be part of that, what are the key messages around well-being. And we equally kind of found that there weren't necessarily clear shared communications channels to be able to deliver messages in terms of trying to engage people with this piece of work, but also in terms of then feeding back to them about the findings and then running any campaigns from that point. So I think those were the kind of main reflections that we had and the recommendations that we made. So I'm happy to take questions now or to hang around and be part of a discussion later if that's helpful.
Thank you, Matthew, and massive amount of information there and some fascinating findings. And I think that's sort of interesting. It's interesting thinking about the explosion in the infrastructure for digital support that's happened since then, and thinking about perhaps the weight management project that's going to be done across the arcs. It's really important that we think about how that is accessed and by different groups, as well as impact, but also how it's accessed and those that perhaps aren't able to access those. So that's part of what that evaluation will be. I think there are masses there, and that report Matthew has made available, and we will put on a link to it on our website so you can look at that full report. I think what I'm going to do is invite our next speaker, and then perhaps have a pause if there's any questions for both either Matthew or for Guy. So I'm really pleased to welcome Dr. Guy Pilkington. So I think probably doesn't need much of an intro, but Guy is the chair of the Integrated Care System Prevention Board, and of course is a GP and is deputy lead for this theme. So Guy, it was your board that commissioned that piece of work, and you're going to tell us a little bit about the sort of priorities for prevention and opportunities. So thank you, Guy.
Thank you very much. Can you hear me okay?
We can.
Great. So Ashley's warm welcome was very heartfelt, I know, because Ashley knows what a relief it is to actually have me on the call at the time I'm meant to be here. So she's worked with me long enough to know that sometimes that's rather precarious. Anyway, thank you very much for the invitation. I only have a few slides. Oh, somebody shared them for me. Brilliant. Is that you, Mackenzie, in the background, moving the slides? I'll give you a shout when I move on. Lovely. The first thing to say is I'm a GP, and I used to be a commissioner at Newcastle Gateshead CCG. I used to chair it for the last few years. And in that role, I was promoted, volunteered into the chair of the North East North Cumbria Integrated Care System Prevention and Population Health Board. I think we have managed to do over a number of years quite a large amount of thinking at leadership level within the ICS to get the North East and North Cumbria to acknowledge that as regions in England go, we are the one that will most benefit from preventative approaches to health and care in an attempt to close what we call the health gap. There have been lots and lots of high-level reports.
Guy, I'm sorry to interrupt. Guy, can you hear me? Guy, can you hear me? Your volume keeps coming and going, Guy. I don't know whether it's your speaker or what, but we keep losing you.
Hello.
Hello. We can hear you. We can hear you now. Let's try with that, Guy. Thank you.
I'm trying to lip read, Ashley. Can you?
Can you not hear me?
I can't hear you, but don't worry about that. Can you hear me? Okay. Is it better than it was? Much better now. Okay. I'll have to switch back to this when we get to questions.
Okay.
Apologies. The North East and North Cumbria, I think, as an ICS, has committed in a very significant way to understanding that preventative approaches are essential if we are to close the health gap. The health gap being poor health outcomes in the North East and North Cumbria compared to other regions of the country. Yet we continue to have some of the most outstanding services from health and social care. If you know that services aren't closing that health gap on their own, then you do have to get into a space that acknowledges that the inequalities of the population that we're looking after experience, and the lack of focus on preventative approaches, much of which we heard about in the last discussion, is the place that we have to develop and grow. The first couple of slides just acknowledge what I think is the two sides of the same coin. I think preventative approaches are the way in which inequalities can best be addressed. We spend a lot of time talking about the two things as being joined at the hip in very significant ways. And the NHS is committing to enormous amounts of focus on inequalities itself. We have the inaugural meeting of an ICS Health Inequalities Advisory Group on the 3rd of July. This is going to be chaired by Julie Gillen, who's Chief Exec at North Tees and Hartlepool Foundation Trust. She has been a great champion of the prevention approach. She's been a member of our board for a long time, and it is not insignificant that a chief exec of a foundation, acute foundation trust, feels it is worth her time chairing the inequalities group. Next slide, please. What I've been asked to talk about is a little bit of what our agenda at the Population Health and Prevention Board is. The ARC, as you know, is all about collaborations around the big health issues of the day, for health and care issues of the day for our region. And I suppose one of my roles is to do this, is to help communicate to the academic community what the big questions are for us within the care and health provision sectors. Ashley, for example, is a member of our board, and she comes along and listens to our conversations, adds huge amounts of value in terms of her knowledge around what the academic opportunities and so on are going on in the background, and she also picks up ideas and opportunities. So this is not new to Ashley, and Ashley represents all of you from academia on the board. But this is a quick summary of our main priorities. What you will see is that our board sits under the management executive of the ICS. We have this newly forming ICS Health Inequalities Advisory Group up there at the top of the page as well. And what you'll see in the blue boxes, and presumably these slides will be shared with attendees, is a summary of the key priorities that we have. And within them, you'll see the names of clinical leads, of public health leads, and often, and I'll make reference to these, the project support officers for that theme within our agendas. And if you have a question or a query about a particular area and you want to know the answers, they are the best person to go to. They'll be easiest to contact, and they will have their finger on the pulse of what that theme is working upon. Nobody will be surprised that reducing tobacco harm and alcohol harm are our two single dual highest priorities in the North East and North Cumbria. We have some very important initiatives, which I'll update you on in a second, that are starting up now, linked into research opportunities as well. The question of healthy weight has been a little bit of a thorn in our side for a number of years, not because it isn't critically important, but because there is a debate within the public health world within local authorities about how much the NHS approach adds to the preventative approach of trying to change the built environment, opportunities for healthy transport and so on, versus what the NHS has traditionally been asked to do, which has been some treatment services for people with unhealthy weights and obesity. That debate has kind of been put to bed now. We know that we have to get on board with the joint challenge around healthy weight and supporting people to have those healthier lifestyles. Obviously brought into sharp focus by the COVID pandemic and the worse outcomes for people who have weight difficulties. Population health management is an enormous part of this, and Edward Kanunga has just been appointed to be director of the population health management work. He's been working in that space for a long time. Really pleased that he's taking that on for I think at least 4 days a week now. Edward is a great champion for population health approaches, in which people are helped to understand what the biggest determinants of the population outcomes within different geographies are, and how we can use data to advise and guide the things that we collectively do. The creation of primary care networks, groups of GP practices, given a population focus, a registered population focus, is clearly a great opportunity for those approaches to embed in the way that general practice and their groups think. DPEN sits underneath the population health management and is essentially a network of practices in the North East, North Cumbria, based on the Scottish model that essentially responds to what Health Foundation published about a month ago, which is there is inequity in primary care resourcing, that it's inappropriate for the population needs, and they talked about how if there is to be a levelling up agenda for the population, we should be pushing for a levelling up agenda for general practice. The evidence is that practices working in the most deprived communities have approximately 8 or 9% less funding per head of population than in areas of affluence. And then increasingly, we are working with the local maternity services grouping for the North East and North Cumbria. Wendy Burke, Public Health, Director of Public Health for North Tyneside, is the Public Health Lead, supported by Becca Scott in a managerial capacity. We're doing various things there that blur into the smoke-free efforts, and we've supported the development of an app for pregnant women and their partners, which is going very successfully. Down the bottom, enabling work streams around workforce, supporting workforce. So when we heard about how MEC is not as widely embedded in terms of skills and so on, that's where a lot of that work needs to go on. Social prescribing and community-based assets is another enabling work stream that runs across so much of what we do. So nearly done. The next slide, please. I'm just going to remind people of some of the detail that I probably haven't already mentioned. So in smoke-free and alcohol work, we have agreed that we will be supporting trusts to develop acute tobacco dependency services. This involves people taking the opportunity with all inpatients to use it as a teachable moment, an opportunity for people to get on board with smoke-free support, partly because NHS trusts are smoke-free and they aren't allowed to continue to use tobacco. Similarly, we are hopeful that the North East is going to have a large number of new funded acute alcohol harm teams called ACTs. They used to exist. They had a very strong evidence base of value. They disappeared and now they're being centrally funded. But what we're doing as a board is augmenting the funding of the ACTs with what we're calling recovery navigators. This is based on a model, again, that came out, I think, of Glasgow, where they had violence reduction navigators linked to alcohol care teams. And they were designed to pick up people whose use of alcohol was a symptom of very chaotic and vulnerable lifestyle, often involving violence, either meted out or received. We think that calling them violence navigators is less helpful, so we're calling them recovery navigators, and we want to fund them linked to the acts that are going to be developed across the North East. A couple of big media campaigns have gone on funded through Fresh and Balance recently, taking that kind of communication to a very large population level. Deep End I've mentioned, and we're doing some interesting stuff with the most deprived practices across the North East. There are 34 that are described as the core group. We've had a number of webinars. We've had Claire Bambra present, and people were fascinated by her syndemic pandemic description, and clearly we know that there is trouble still to rise to the challenge of in terms of those inequalities and deep economic inequalities following on from the pandemic itself. I've talked a bit about the population health approach, the public maternities there. So yes, smoking in pregnancy has been a focus recently, and we are having some evaluation of that app. But also clearly we know that there's lots more around lifestyle and breastfeeding and use of alcohol and so on that we are supporting tangentially with the LMS, the Local Maternity Services Group. Next slide, please. Nearly done. Population health management approaches, particularly embedding and supporting primary care networks. Edward and Amanda Healy, the DPH from Durham, did some interesting pilot work around their PCNs and using data to inform the way that PCNs are focusing on population level interventions, which I think is a very welcome new development for most GP practices. Healthier weight, there is a piece of work happening now, and Ashley made reference to the fact that we've recently heard that the national app evaluation is one of our national prevention projects, and Ashley can, maybe you've already mentioned it, Ashley will certainly be able to tell anybody more about that, liaising with Oxford and probably about another 9 ARCs across the country or something. Our main focus in that area is around the acute tobacco dependency, and that clearly is a major new NHS intervention that we need to understand and evaluate on a national footprint. I mentioned MEC and so on. It's interesting, we heard earlier that a lot of frontline workers don't think it's their role to talk about some of the determinants with people or what matters to them or their lifestyle choices. And when you think that actually for certain conditions, let's take smoking and diabetes, let's take smoking and respiratory disease, there actually isn't a evidence-based intervention of greater value to people's medical health than stopping using tobacco. And yet we somehow or other don't believe, or many people don't believe, it's part of our role to promote smoking cessation. Social prescribing, very interesting stuff that we saw earlier about how people, if they were unemployed and if they had long-term conditions, struggled sometimes to feel that they were being listened to and their needs were being appropriately addressed by services. Social prescribing fits into that space, and I've been personally involved with a major social prescribing initiative many of you will have heard of called Ways to Wellness, which is absolutely designed to sit exactly in that space. And that's been heavily evaluated and researched by Newcastle and Durham universities. And the results are soon to be published. Next slide. I'm not sure there's much else. So lots and lots of opportunities going on, lots of areas that the ARC is already involved with. What I'll do, I think I've shared also with the team the newsletter that we produced back in January. There is a second newsletter being written as we speak. And again, we can circulate that to anybody on the call via the Prevention ARC team. I think there are still unexplored opportunities, and if people have interest in any of those themes, then please do get in touch and we can put you through to the project manager who will have their finger on the pulse, as I said earlier.
Okay.
I'm going to have to switch.
Thank you, Guy. I think Guy's point is very well made. I think some of the work that Guy's talked about, particularly around smoking cessation and pregnancy, and doing some evaluation on that. There are real opportunities in terms of the work of that prevention board for opportunities for research and for evaluation. And if anybody's heard anything there today that you'd be interested in, Guy mentioned I do sit on that board. We will share those newsletters with people to be able to we'll put the links to those onto the website so that you can access those. I'm just going to pause for 1 second if there's any burning questions for Guy, but I'm also aware of time. Please put things into the chat. So anybody want to ask any immediate questions of Guy before we move on to brief intro to our public involvement, community engagement? Okay. So you all asked to hear more about the ICS, and now you know much more about the ICS, and we'll make sure that we continue that that link in. Can anybody see any hands up? I don't have any, so thank you very much. Thank you very much, Guy.
Actually, just enthusiasm for the newsletter from Peter van der Graaf in the chat.
Oh, okay, yeah, I see that. So thank you. We've got some comments in the chat there, Guy. So thank you. So what I'm going to do now is very briefly introduce Dr. Lorraine McSweeney. We have 3 link groups from across our ARC, one on implementation, one on capacity building, and one on our public involvement and community engagement. And we're just going to introduce Lorraine to you. I'm really delighted to see some of our public members with us today. Lorraine, just briefly to introduce yourself to people. Thank you.
Hi, thanks, Ashley. Yeah, so as Ashley said, I'm the theme lead for the prevention theme for the PEIBC. So I'm just going to give you a very brief update of all the great PEIBC work that's been going on within the OFC 20 funded projects. And I want to thank everybody for providing me with your updates. So next slide, please, Bryce. So you've been thinking of some innovative ways to involve or engage the public. Some of these are already set up or you plan to do so in the future. So we've got some people using lived experiences by providing networks and groups. You've been running public events, campaigns, knowledge cafes, you're using advisory groups and expert panels. Next slide, please. So despite us being in the midst of a pandemic, you haven't let this stop you continuing with your PEIBC activities. And although most activities have had to move online, you've still been able to run workshops and focus groups. And some of your members regularly attend steering groups or project management meetings. And you've consulted or involved members with reviewing or developing study protocols, materials, and co-authoring study outputs. Next slide, please. I just want to remind you to think about how you plan to evaluate all your PEIBC activities and outputs. And remember, doing so will help you towards achieving your Dialogue and Change Award. And this is mandatory for all OFC 20 fund holders to achieve before the end of your project. I recently shared the details of a workshop being held by ARC, which is looking at embedding PEIBC into research practice, and it's been held on the 21st of July. So if you haven't already signed up, you can still do so. And also, if you haven't seen it, the ARC website has details about further training opportunities and links. Next slide, please. And finally, remember, if you need any sort of PEIBC support or advice, you can get in touch with me, or you can get in touch with our ARC PEIBC manager, Felicity Shenton. So continue the good work, and thanks again for your updates. Thank you.
Thank you, Lorraine. And there is a huge amount of work going on with the links across the themes with Felicity Shenton, and it's great to have Lorraine in that place. So please do follow the advice that Lorraine's given you, and reach out to Lorraine if you need some support or direction to where to find those resources. And she's mentioned the workshop. Okay, so if we could stop sharing slides, please. We're going to move now to having a really brief opportunity to break out into some groups and meet